Good morning, everyone. I'm going to turn it over to Jim now to introduce our speaker.
Hi, good morning. Welcome to our virtual grand rounds. And this morning, we're thrilled to be welcoming as our speaker, Dr. Aimee Lucas. Dr. Lucas earned her medical degree from the Yale University School of Medicine and completed a Howard Hughes Medical Institute research fellowship, followed by residency training in internal medicine at Columbia University, where she also served as a chief resident. She then pursued fellowship training in gastroenterology, also at Columbia, where she served as a chief fellow and earned a master's degree while there in patient-oriented research from the Mailman School of Public Health. As a member of the faculty here at Mount Sinai, Dr. Lucas serves as an associate professor within the Division of Gastroenterology. In addition to her clinical practice, in which she cares for patients with a full spectrum of gastrointestinal disorders, Dr. Lucas is an active researcher in the development of screening regimens for patients with hereditary cancer syndromes. She has also authored publications in multiple journals within gastroenterology and oncology, and is a fellow of the American College of Gastroenterology, as well as the New York Society for Gastrointestinal Endoscopy. Good morning, Dr. Lucas, and welcome.
Good morning. Thank you so much, Jim, for the invitation to present today, and also to Dr. Murphy and Dr. Thomas for the opportunity to present today. And most definitely thank you to Francine for arranging everything to be so seamless. I'll discuss hereditary pancreatic cancer today, one of my favorite, I feel, slightly underappreciated topics, but we'll review some basics on pancreatic cancer. And then we'll move into our other learning objectives, which are to define individuals that are at increased risk of developing pancreatic ductal adenocarcinoma. And for this talk, when I speak about pancreatic cancer, we will be discussing ductal adenocarcinoma, not focusing on neuroendocrine tumors or other tumors of the pancreas. We'll describe an appropriate surveillance strategy for individuals who are at an increased risk of pancreatic cancer. And we'll review two important updates, one of which is a U.S. Preventive Service Task Force recommendation about screening for pancreatic cancer. And the second is a recommendation on germline testing for pancreatic cancers. So as many of you know, pancreatic cancer is an often devastating diagnosis. These are estimates from 2020, and pancreatic cancer, barely makes the top 10 lists of new diagnoses annually for cancer, with about 58,000 new diagnoses every year. However, when you look at estimated mortality from pancreatic cancer leaps up to the number 3 cause of cancer death in the United States, with about 47,000 cancer deaths. These two numbers used to be nearly equal, with near equal incidence and mortality. And this does reflect some improvements that we've made over the past years on pancreatic cancer survival and mortality. But you see here that overall survival for pancreatic cancer for the years 2009 to 2015 across all stages is approximately 9%. Currently, the vast majority of patients are diagnosed with metastatic disease with 5-year survival of only 3%. Early stage cancers, however, do have improved survival, and most recent SEER data suggests that stage 1 cancers, pancreatic cancers, may have 5-year survival up to approximately 85 to 87%, suggesting that a stage shift to earlier stage of disease may indeed improve survival. When we look at trends in death rates over the years, we can see that overall survival for pancreatic cancer has remained relatively flat, while we see nice decreases in, for example, colon cancer mortality, as well as lung and bronchus mortality after tobacco cessation and other interventions. Although we see pancreatic cancer sort of slowly plugging along with subtle increases over the years. There are several studies that have suggested that pancreatic cancer may be the second leading cause of death on and around the current years. This is a modeling study that was published 7 years ago now, looking at trends in cancer mortality. And what you can see is that the authors estimated that by 2030, and probably around current time, pancreatic cancer would actually surpass colorectal cancer and become the number 2 cause of cancer mortality in the United States, only second to lung and bronchus cancer. What's perhaps underappreciated, however, is the role that a family history or genetics or some sort of inherited predisposition to pancreatic cancer plays in pancreatic cancer development. I think many of us, when we see patients who've been diagnosed with pancreatic cancer, it often happens to an older individual. Perhaps the individual is overweight, perhaps there's a tobacco history, a heavy alcohol history, or other risk factors, or we just chalk it up to bad luck. And that's not entirely the case. Probably about 10 to 15% of patients with pancreatic cancer do have some sort of familial aggregation. And so these are data that are over a decade old now, but are the standard data that we reference when we're talking about increased risk with a family history. This comes from Alison Klein and the Johns Hopkins group, who has probably in the United States the longest and largest running study of hereditary pancreatic cancer patients. And what they did was that they assessed the standardized incidence ratio for pancreatic cancer compared to the incidence in the general US population, which at that time was 9 in 100,000. And they looked at individuals who by number of first degree relatives. And so a first degree relative is essentially a mother, father, sister, brother, or child. So one step off in the family tree. And if you have one first degree relative, the standardized incidence ratio is 4.5. So it does seem to be somewhat increased, although this confidence interval does cross 1 and is quite broad, suggesting that it's probably a mixed bag population. And I'll get to some of my hypotheses on why this is later on. However, when you have 2 or more first degree relatives, your standardized incidence ratio is significantly increased. And 3 or more, even more so. This led to a working definition of familial pancreatic cancer, which has gone through several iterations, which you can see here. But by and large, we describe a familial pancreatic cancer kindred as a family that has at least 2 first-degree relatives who have been diagnosed with pancreatic cancer. So for example, this is a family with a parent, perhaps a father with a paternal aunt, or a father with a paternal grandparent who has been diagnosed with pancreatic cancer. Other definitions you can see here, which are 2 or more first degree relatives with pancreatic cancer. It's a little bit tough to think initially how this is different, but this could be somebody with a parent and a child, 2 or more affected blood relatives, one of whom is a first degree relative. So this is perhaps somebody who has a parent and a cousin, or 2 or more second degree relatives, one at an earlier age. I'll review here some of the inherited syndromes that predispose to pancreatic cancer just to set the tone, and then we'll review some of the data supporting these associations. So in addition to having familial pancreatic cancer as a risk factor, and that is when we don't have an identified germline mutation, some of these syndromes can also predispose to pancreatic cancer. So we have the hereditary breast and ovarian cancer syndrome, largely caused by pathogenic variants in BRCA1 and BRCA2, which we know well from their risk of breast cancer, ovarian cancer, as well as prostate cancer and melanoma. And these carry a relatively modest relative risk of pancreatic cancer, probably somewhere between 2 to 9. PALB2, or partner and localizer of BRCA2, also carries an increased risk of pancreatic cancer and is associated with breast cancer, as are pathogenic variants in the ATM mutation, otherwise known as ataxia and telangiectasia. If you inherit 2 copies that are mutated, you wind up with ataxia and telangiectasias. But if you have 1 mutation, you have a modestly increased risk of pancreatic cancer as well as breast cancer. The familial atypical multiple mole melanoma syndrome, or FAM syndrome, which is caused by pathogenic variants in CDKN2A, carries a very increased risk of pancreatic cancer as well as multiple nevi, dysplastic nevi, and melanoma. Peutz-Jeghers syndrome, which is a hamartomatous polyp syndrome caused by mutations in STK11. Patients have a characteristic hyperpigmentation around the buccal mucosa and other parts of the bodies, carries a very increased risk of pancreatic cancer. Lynch syndrome, caused by mismatch repair genes, MLH1, MSH2, MSH6, PMS2, and EpCAM, well known for risk of colorectal cancer, as well as endometrial and other cancers. also carries a modest increased risk of pancreatic cancer. Hereditary pancreatitis, which is quite rare, caused by mutations in PRSS1, carries an increased risk of pancreatic cancer. And the literature describes an association with familial polyposis or APC gene mutations in pancreatic cancer. We learn about this one in medical school due to its risk of colon cancer and colons that are, essentially carpeted in polyps. It's unclear if this is an association with pancreatic cancer or ampullary tumors that are misclassified, but I leave it here on the list because we do see it described. So our real question is, these germline mutations in pancreatic cancer, are they causal or are they just associations that we see? So we looked at a series of patients who underwent pancreatic resections who were of Ashkenazi Jewish descent, looking for BRCA1 and BRCA2 pathogenic variants. The reason we could look easily in this population, and this study is now, we did this nearly a decade ago, was because there are three founder variants that are found in an Ashkenazi Jewish population at greater prevalence than others. So the overall population prevalence of these three variants, which you can see in panel B on the bottom left, in the United States is about 2.3 to 2.5%. And what we did is we looked in our Ashkenazi Jewish cohort who had undergone any surgical resection for adenocarcinoma, or surgical resection for IPMNs, which is a cystic lesion, which is a precursor for pancreatic cancer. And what we found is that approximately somewhere between 19 and 20% of individuals who underwent surgical resections or resections for cancer actually harbored pathogenic germline variants in these three founder mutations. Since that time, our ability to perform whole exome sequencing and much more detailed germline analyses has really expanded. And other groups have done this in supposedly unselected cohorts of pancreatic cancer patients. So I realize that this table is quite busy, and I don't expect you to sort of memorize right off the bat the panel in the left column. But you can see here in this cohort column that we have relatively large cohorts from large institutions, Johns Hopkins, Pittsburgh, Mayo Clinic, Dana-Farber, Brigham and Williams. And they looked at consecutive patients with pancreatic cancer. They interrogated them with panels of germline genes, ranging from approximately 13 genes to 32 genes. And what they found is that somewhere between, let's say, 4 and 10% of unselected individuals with pancreatic cancer harbored pathogenic germline variants in a variety of genes that have been associated with pancreatic cancer. And the genes that were identified, you can see over in the right column, should start to look familiar to you because they're the genes that we described in one of the previous slides. Largely ATM, BRCA1 and BRCA2, some of the Lynch syndrome genes, P53, which is associated with Li-Fraumeni, and a variety of other pathogenic gene mutations. What you can see here in the third column towards the bottom is that if you select the individuals, and this was done at Mayo Clinic, who have a first-degree relative or a second-degree relative with pancreatic cancer, and you look at how many of them have pathogenic germline variants, you can enrich the population to approximately 13% or so of individuals with pathogenic germline variants. And conversely, if this is what Dana-Farber did, if you look at individuals with pathogenic or likely pathogenic germline variants who had a family history of pancreatic cancer, you find these germline variants in about 21% of individuals. So this tells us that if we look at individuals with pancreatic cancer and we interrogate their germline, we will find pathogenic variants that are associated with not only pancreatic cancer, but other cancers as well. The Mayo Clinic was able to take this one step further, and they not only sequenced their pancreatic cancer cases, but they were able to sequence a number of control patients without pancreatic cancer. And what they did from there was they calculated an odds ratio for development of pancreatic cancer based on the gene mutation, trying to get at the question of causality versus association. And what you can see here is that pathogenic variants in CDKN2A, P53, MLH1, BRCA2, ATM, and BRCA1 are all associated with significantly increased odds ratio for development of pancreatic cancer. I leave PALB2 here at the bottom because even though it did have an increased odds ratio, the authors of this study did not feel as if that increased odds ratio was enough to warrant further investigation or essentially screening or surveillance for pancreatic cancer, which we'll get to towards a little later in the talk. The University of Pittsburgh has also looked at this from a different angle. They took nearly 1,300 patients with pancreatic cancer and looked at 149 who had what they described as another relevant cancer. These relevant cancers at the time were those that were associated with a hereditary breast ovarian cancer syndrome or a Lynch syndrome related cancer. And they had 124 individuals who met these criteria undergo genetic testing. And they were able to find pathogenic germline variants in 18% of individuals with pancreatic cancer who had another relevant cancer, personal history. And if they excluded prostate cancer, the mutation prevalence increased to 23%. And once again, this list of genes is going to start to look familiar. They found mutations in ATM, BRCA1 and BRCA2, CDKN2A, some of the Lynch syndrome genes, BRIP1, PALB2, and P53. And what's important to note here is that approximately a quarter of mutation carriers actually did not meet NCCN criteria at that time for hereditary breast ovarian cancer or Lynch syndrome testing guidelines based on their personal cancer history and family history. So even if we were able to ascertain a complete family history in these individuals, they would not meet NCCN criteria for genetic testing. And so therefore that would not be offered or largely covered by insurance payers. I do want to take a step back and say that smoking is still the major known risk factor for this cancer. It's associated with approximately 30% of all cases. It makes the tumors grow faster. Smokers do have a younger onset, and it does appear to be dose dependent, even in the setting of a family history. So the family history and the germline mutations are not everything. So this is again from Allison Klein's study from 2004, where they looked at the standardized incidence ratio for those with at least a first degree relative with pancreatic cancer. And the risk for smokers was about threefold higher than the risk for non-smokers, even in the background of the same strong family history. So now that we know that there are individuals that are at increased risk of developing pancreatic cancer, can we prevent them from developing pancreatic cancer, or can we diagnose it at a treatable stage? So instead of having 80% or so of pancreatic cancers diagnosed with metastatic disease, can we embark on a stage shift and move that earlier so that we can adequately treat it? So I'll review here what our options are for current day pancreatic cancer surveillance. We use largely two techniques. One is endoscopic ultrasound and the other is MRI. So first, endoscopic ultrasound. This is an endoscopy procedure. It utilizes the same anesthesia that we typically use for a routine upper endoscopy or a colonoscopy. So it does require sedation. The endoscopist inserts the endoscope through the mouth, goes down the esophagus into the stomach and the first part of the small intestine. And from the stomach and the small intestine, we can visualize through ultrasound the pancreas. That does give us the ability to sample any abnormalities right on the spot if we see them. But since it is an invasive procedure, some patients are a little bit hesitant to undergo this as an initial surveillance tool. The other thing that we can use is magnetic resonance imaging, typically with an MRCP image, which would give us a nice look at the pancreatic duct, as well as any cystic lesions in the pancreas. The advantage here is that it is a non-invasive study. It does not include radiation or anything else that some of our patients who are at increased risk of cancer might be concerned about. There are some concerns more recently about the long-term impact of gadolinium exposure repeatedly, and we're also unable to biopsy anything at the time of MRI. And so, if there is something that's concerning, patients need to move on to endoscopic ultrasound. And one of the big limitations is really patient tolerance. So it's only as good as our images. And if somebody is unable to lie still in the MRI machine for half an hour or 45 minutes, it can be challenging to acquire adequate images. What are we looking for when we perform surveillance? We're looking for precancerous lesions. And so we have some of those in the pancreas. One precancerous lesion or neoplastic lesion is called a PanIN lesion, or pancreatic intraepithelial neoplasia. These are small intraductal lesions formed by abnormal proliferations of ducts within the pancreas. They demonstrate varying degrees of dysplasia. Previously, this was PanIN 1, PanIN 2, or PanIN 3. Some now classify this as low-grade PanIN versus high-grade PanIN. Some pancreatic cancers arise from PanIN, but not all PanIN become cancers. And indeed, if we do autopsy studies, somebody walks across the street, gets hit by the bus, we find PanIN lesions in many older individuals, but clearly not all of those individuals develop pancreatic cancer. And the most challenging part about PanIN lesions is that we really don't have a good tool to visualize them clearly on imaging. There are some that feel as if there is a unique descriptor in the pancreas called lobulocentric atrophy, which we can see perhaps on endoscopic ultrasound. But by and large, for people who move on to pancreatic cancer through the PanIN pathway, our target for detection is a small solid lesion, which typically represents an early stage cancer. We also have several cystic lesions in the pancreas, which we're identifying more and more in the general population. The two that I'll focus on here that do have cancer potential are mucinous cystic neoplasms, or MCNs. These are typically described as having ovarian stroma, possibly arising from ovarian rest within the pancreas, and are seen almost only in women. And the risk of invasive carcinoma ranges somewhere between 6 to 36%. And then the lesions that we see most often on any number of CT scans, MRIs that are done either for the purpose of imaging the pancreas or otherwise, or some other cause, are IPMNs, or intraductal papillary mucinous neoplasms. These are classified into two different types, one of which is a branch duct IPMN, the other a main duct IPMN. And these carry different risk of malignancy, with the main duct IPMN carrying a much higher risk of malignancy. What we perhaps have not understood to any degree was the duration that it takes to go from a normal tissue from PanIN 1, 2, 3 onto cancer. And so perhaps about a decade ago now, the University of Nebraska and others performed actually rapid autopsies on patients who had passed from pancreatic cancer. And what they did was they used mathematical modeling to look at the time sequence that it took in the primary tumor, as well as some of the metastases, and estimated the time sequence from normal tissue to advanced PanIN, from cancer to the opportunity for metastases. And their results were actually quite surprising, which is that it took about almost 12 years to go from normal tissue to high-grade PanIN. And the time to go from a high-grade PanIN onto cancer was nearly 7 years. And then time from cancer development to patient death was about 2.5 years. And what I think this suggests is that the clinical diagnosis and our overall perspective of what pancreatic cancer is, which is largely a diagnosis at late stage disease to, you hear the story of somebody lasting a month, 2 months, 3 months, perhaps 6 months until death. means that what we see from pancreatic cancer and after the diagnosis of pancreatic cancer is really just the tip of the iceberg. And there are ample opportunities to identify cancers before the metastatic stage or even at a precancerous stage. All right, I'll shift gears now because this is a question that often comes up. Well, oftentimes we don't have the individual who was diagnosed with pancreatic cancer. So what do we do for asymptomatic family members? And can we do clinical genetic testing for those individuals? So what we typically do in the office is construct essentially a 3-generation pedigree. We look at the patient themselves. We take a detailed family history in their parents' siblings, their first cousins on either end, and then the 2 grandparents on the maternal and paternal side. I work very closely with the cancer genetic counseling group. And often we're referring patients to the cancer genetic counselors, and I receive patients from their referrals. And although we've been doing this for some time, there was limited evidence previously for pancreatic cancer, with the exception of those who met clear criteria for well-described hereditary syndromes, like the hereditary breast ovarian cancer syndrome. Part of that is because until 2013, one company actually had the patent for BRCA1 and BRCA2 genes. So there was literally one shop in town in the entire country where you could get testing. And so they essentially set the prices, which if it wasn't covered by insurance, and it would only be covered by insurance if people met these very stringent criteria, the cost for sequencing for the 3 Ashkenazi Jewish founder mutations was somewhere in the range of $300. But if you wanted a full gene analysis and rearrangements, the cost was $3,000. And so this was really cost prohibitive. And so we weren't able to perform genetic testing really prior to 2013 on all of our patients. After 2013, you can see this case actually went to the US Supreme Court, and they no longer have the patent for the BRCA gene. And we had technology advances, which allowed for more high throughput gene sequencing, and the competition also lowered costs. And so now, nowadays, we can do genetic testing in a different sort of manner. But what we used to do is take this history physical exam and categorize individuals into average risk, moderate risk, and high risk. And the way I thought about this, and still sort of think about this, is that average risk individuals, and these criteria have changed over the years, were those with one family member with pancreatic cancer. High risk individuals were those with familial pancreatic cancer or a genetic syndrome associated with pancreatic cancer. And then the moderate risk individuals were those who didn't quite meet either criteria, but seemed to be at increased risk. For those that were at average risk, we did not perform any screening or surveillance, and those that are at high risk received endoscopic ultrasound, MRI. At that time, we were doing CA 19-9. And there's a lot of interest in the association between diabetes and pancreatic cancer, which I'll touch on a little bit later, and we were doing oral glucose tolerance tests at that time. If there were any abnormalities, we would perform an endoscopic ultrasound if that hadn't been performed already. And so what we did was we actually incorporated germline testing, largely for BRCA1 and BRCA2, into our screening and surveillance strategies. So we took an individual cohort, initial cohort of patients, and even if they were at average risk, we said, we're going to do this as a research study and apply genetic testing. And based on your genetic testing results, we'll recategorize you into average risk, moderate risk, or high risk of screening. And what you can see is that what we were able to do was reclassify several individuals who are average risk and therefore never would have received any screening or surveillance, or moderate risk into the high risk category, and then apply surveillance with either MRI or endoscopic ultrasound. And what we find is that when we do screening or surveillance in a multi-organ fashion, and so this includes taking, referring to our gyn-onc colleagues, our breast colleagues, we find significant findings in about a third of individuals. So for our BRCA1 mutation carriers, 2 of them had really pertinent findings. One was a pancreatic cancer at the time of initial examination. And second was an ovarian cancer at the time of what was supposed to be a prophylactic hysterectomy and oophorectomy. For our BRCA2 mutation carriers, we also found a pancreatic cancer on screening, but we also find these subtle abnormalities that we don't quite know what to do with, but warrant surveillance. So a 5 millimeter dilated pancreatic duct may represent a main duct IPMN, but we have to follow it. And then commonly we see individuals who have small cystic lesions in the pancreas. And in this series, we also found an individual who had both a cystic lesion in the pancreas, low risk cystic lesion, less than a centimeter, as well as a cancer, again on prophylactic, what was supposedly a prophylactic hysterectomy and oophorectomy. We did not see any differences at age of initial screening, tobacco or alcohol history, family history of pancreatic cancer or other BRCA-related malignancies. But as you saw on the previous slide, this was a relatively small study, and so we were underpowered to detect these differences. The Johns Hopkins group has looked extensively at their findings on surveillance. And so this is one of their representative studies where they actually had 216 high-risk individuals undergo screening and surveillance with CT, MRI, and endoscopic ultrasound. So all individuals had all 3 exams, and it was described to happen in a blinded fashion. And what they found was that looking at any lesion, and this included solid mass, cystic lesions, mural nodules, which is a finding that we associate with high risk of pancreatic cancer development. Approximately 11% of individuals were found to have any lesion on CT, but MRI and endoscopic ultrasound really showed us many more findings. Whether or not those are ultimately clinically relevant is another question. But when they looked at the combination of CT and endoscopic ultrasound, they actually found that this missed about 7% of the cysts that were seen on MRI, and cystic lesions in the pancreas are a type of precancer, and so this is an important thing. And the combination of CT and MRI actually missed about 22% of the lesions that were seen on endoscopic ultrasound. 3 of those lesions were solid neuroendocrine tumors, and 4 of them were dilated main pancreatic ducts. And so this started a conversation about whether or not we should use CT as a surveillance mechanism, since it does seem to be inferior and also includes radiation. But 2, whether or not endoscopic ultrasound and MRI are actually complementary, or if we could use one or the other. And so born out of this study was the recommendation for either MRI or endoscopic ultrasound as acceptable tools for surveillance of high-risk individuals. One of our European colleagues has also tried to look at this question of solid lesions versus cystic lesions, and they actually found similar findings to Mimi Canto's study from the Hopkins group, which we looked at on the previous slide, which is that endoscopic ultrasound seems to be slightly superior for detection of small solid lesions, whereas MRI seems to be a little bit superior for detection of cystic lesions, particularly cystic lesions that are greater than a centimeter in size, which are the ones that we start to look at a little bit more carefully. And so this really continues the conversation about whether or not one exam is better than the other, or if the 2 exams are really complementary. So we looked at this in a meta-analysis, and this is a study that was done largely by Nina Kokegar, who is in a hospitalist year now and starting a GI. She's a Sinai resident, first of all, and she's starting her GI fellowship at Montefiore next year. And also Kelly Diaz, who is also a Sinai resident, who is a GI fellow at the University of Virginia. And so we performed a meta-analysis of high-risk individuals trying to get at this question of endoscopic ultrasound versus MRI. And so Nina and Kelly reviewed over 1,300 studies, excluded redundant articles, irrelevant articles. We carefully reviewed 129 full text studies and ultimately included 24 cohort studies, largely in our analysis. We only included studies which reported focal abnormalities detected at baseline imaging for this overall analysis. And we only looked at initial pancreatic imaging because subsequent follow-up imaging was reported somewhat sporadically and inconsistently throughout the studies. And what we found is that about endoscopic ultrasound picked up pancreatic abnormalities in about a third of the time, but not unexpected was that endoscopic ultrasound showed us slightly more abnormalities than MRI when we're looking at focal pancreatic abnormalities. When we looked at the proportion of patients with high-grade dysplasia or early resectable cancer, and we'll look at this at the very end of the presentation, but these are really our targets for screening and surveillance, we found that there was actually no difference between endoscopic ultrasound and MRI at detection of these important endpoints of high-grade dysplasia or early-stage resectable cancers. Similarly, when we looked at the proportion of patients with pancreatic cancer, any cancer across any stage, there was no difference between endoscopic ultrasound or MRI. And when we calculated the number needed to screen to detect a high-grade dysplasia or an early-stage cancer, the number needed to screen was 111. What's important to note here is that the mean and median age for inclusion in many of these cohorts was somewhere between 50 and 56. And we'll get to this later in a few moments, but our current recommendations for screening and surveillance are not to look until a later age. And we know that abnormalities in the pancreas increase as age increases. And so my suspicion is that if we actually applied current day screening and surveillance recommendations to start later, our number needed to screen to detect high-grade dysplasia or early stage resectable cancer would actually come down. Another important point to consider is that over 5% of individuals in these cohorts underwent surgery for lesions at baseline. Surgery is clearly, pancreatic surgery, which is either a Whipple procedure or a distal pancreatectomy. And so it's important to keep in mind that there is real potential for harm for embarking on a surveillance program. And so this is something that we consider very carefully when initiating a discussion with the patient. So getting at the age of onset question, and again, these are data now that are about 15 years old, but I think are still important when we're looking at age of onset. So age of onset for pancreatic cancer is typically in the late 60s to 70s. And so this group looked at the age of onset of pancreatic cancer when there was a family history of breast cancer, ovarian cancer, colon cancer, melanoma, pancreatic cancer, or other cancers. And these four cancers at the top should start to look quite familiar because they are also the cancers that we reviewed are associated with pathogenic germline variants that are associated with pancreatic cancer. So the age of pancreatic cancer onset when there was a family history of breast cancer was slightly younger, about 3 years younger than the age for those who did not have a family history of breast cancer, but it was still about 65. Similar trends can be seen when there's a family history of ovarian cancer, a family history of colon cancer, or a family history of melanoma. Interestingly, though, when there's a family history of pancreatic cancer, the age of pancreatic cancer onset was not significantly less, nor was it lower when you had a family history of all other cancers. So I think the take-home message from this study is that, yes, pancreatic cancer does seem to happen at a slightly younger age when there is a family history of other cancers and that suggests a pathogenic germline variant. But it's not happening typically in a 30-year-old, a 40-year-old, or a 50-year-old. And so likely screening and surveillance can start at an older age. This is another study that was trying to get at the question of what age should we initiate surveillance. And this group looked at pancreatic cancer death as well as all-cause death. And so competing mortality does start to be an issue in older individuals. And what you can see here is for those who have 1 or 2 first-degree relatives or 3 or more first-degree relatives, you really don't see an inflection point where there are more pancreatic cancers until after around the age of 50 or 55. And you can see similar trends for those who have 3 or more first-degree relatives, although perhaps that starts at an earlier age. One of our European colleagues also looked at this, and what they did was look at the age of first screening in years, and it's a busy slide and it's a little tough to digest at first, but what they did in this left-hand column was they split their cohort into those who were under 40 and over 40, and so that's one group that they analyzed, under 45 or over 45, under 50 and over 50, and so on and so forth. And what they did was they looked at individuals at risk. So those are their high risk individuals, that's their term, that had significant lesions detected on screening. They defined significant lesions as pancreatic cancer, high-grade PanIN, or high-grade IPMN, so exactly the target lesions that we've been discussing. And what they found is that if you look at individuals who are younger than 50, you do not miss any lesions. And lesions are only found in individuals who are over the age of 50. And if they recategorize this to relevant lesions, which essentially included some lesions that were sort of slightly less dysplastic, again, you really don't miss any significant lesions if you're looking under the age of 50. Now, one of the big questions when we're doing any sort of cancer screening or surveillance is whether or not it impacts overall survival. And admittedly, we have very little data on survival in pancreatic cancer, and there are always questions about lead and lag time biases. This is a study published again from the Hopkins group, where for the first time, we actually had some data on pancreatic cancer survival. And so this first curve is pancreatic cancers that were detected outside of surveillance. The second curve are survival for pancreatic cancers detected during surveillance. And then the top curve is those who underwent surgical resection or treatment of high-grade dysplasia or high-grade PanIN lesions. And what they found is that median survival in surveillance was over 5 years for those who had a pancreatic cancer detected on screening or surveillance. And this is across all stages for pancreatic cancers, compared to about 1.5 years for those who had a pancreatic cancer detected outside of surveillance. And overall 3-year survival for those with a pancreatic cancer detected during surveillance was 85% compared to 25% in the other group. I'll shift gears a little bit and show some additional interesting data on pancreatic cancer associations with diabetes and hyperglycemia. And so there's a lot of interest now on the association between diabetes, hyperglycemia, and pancreatic cancer development. This is a study that came out of the Mayo Clinic. So it's a Rochester, Minnesota population. And they looked at, it's a case control study, and they looked at patients with pancreatic cancer compared to those who did not develop pancreatic cancer. And they looked at the fasting blood glucose levels in the time period leading up to pancreatic cancer development. And what they could see was that approximately 3 years prior to the diagnosis of pancreatic cancer, you can start to see hyperglycemia, with frank diabetes developing about 6 months to a year prior to the pancreatic cancer diagnosis. As we reviewed earlier, it does seem as if there is significant time for pancreatic cancer development and early detection. And so there are several groups that are doing prospective studies of patients with new onset diabetes, wondering whether or not some of that underlying diabetes is actually due to pancreatic cancer. We also looked at factors that are associated with the presence of a pancreatic cyst in our high-risk population. This is a study done with Ari Baramashai, who is a Mount Sinai medical student who is now a resident at another New York City institution. But he looked at factors associated with the presence of a pancreatic cyst in our Mount Sinai high-risk population. And what he found was that older age, so over 60, was associated with the presence of cystic lesions in high-risk individuals. And we know that, and we've seen that in other studies. But what was new and different about his study was that he found that individuals with a hemoglobin A1C that was in the pre-diabetic or above range also were more likely to have pancreatic cysts. And we use this pancreatic cyst as sort of a intermediate outcome. Our local registry is not mature enough to show overall mortality at this point, but this was a nice start and a nice study for Ari. The Hopkins group has also looked at risk factors for progression for high-risk individuals. And so, we have our individual study, perhaps that shows a cyst, who's at risk of moving on to cancer and who is likely to stay with a small cystic lesion in surveillance. They described any radiologic progression as a risk factor for cancer development, whether it was a cystic change or a solid mass. But interestingly, the total number of lesions at baseline was associated with risk of progression to pancreatic cancer. And so even if our patients have small cystic lesions, which we typically think of as low risk for progression, if they are multifocal in nature, we do keep a closer eye on those individuals. All right, so with all of these data that I've shown you, what are our current guidelines? So the NCCN in the end of 2019, early 2020, actually updated their genetic familial high risk assessment for breast and ovarian cancer to include pancreatic cancer for the first time. And their new recommendation was to recommend genetic counseling and germline testing for all individuals with pancreatic ductal adenocarcinoma. And if those individuals are not available for their first degree relatives. And the minimum panel that they recommend interrogating are these genes shown here, which we've reviewed several times. Essentially, ATM, BRCA1 and BRCA2, CDKN2A, the Lynch syndrome genes, PALB2, STK11, and P53. They do note, based on our study and others, that pancreatic cancer risk is increased in those who are of Ashkenazi Jewish descent, and genetic testing of those who are Ashkenazi Jewish may have a higher yield than we would expect in other populations. ASCO also has a provisional clinical opinion, which was published recently, and I show it to you here. It's essentially that all patients diagnosed with pancreatic cancer should undergo what they call assessment of risk for hereditary syndromes with essentially the same genes. And they comment here in 2.2 that while the individual with a cancer diagnosis is the best candidate to initiate genetic testing, and has the highest likelihood of what we call an informative test result, often that person is not available. And so we can do it in an unaffected individual that's related to that individual, with the understanding that a negative test result is considered clinically uninformative. There are several reasons that the NCCN and others have adopted these new recommendations. One is the opportunity for what we call cascade testing, which is essentially walking down the family tree one by one. And if we identify a germline variant in an individual with pancreatic cancer, we can test their relatives for that same gene mutation. And they have the opportunity of not only having screening for pancreatic cancer, but also addressing some of their other multi-organ cancer risks. So for example, if we identify a BRCA2 mutation in a parent with pancreatic cancer, and they have a daughter who's in their 30s or 40s, she may want to pursue germline genetic testing and then take advantage of the opportunity for breast cancer and gynecologic cancer risk reduction. The second reason for recommending germline testing is actually for the patient themselves. So previously, germline testing for pancreatic cancer was sort of altruistic, and you're doing it for your family members. But now with the advent of PARP inhibitors and other targeted therapies, we do have treatments for those who have pathogenic germline variants in certain genes with some improved outcomes. I would be remiss if I didn't address the U.S. Preventive Services Task Force recommendation, which was updated about 2 years ago from a 2004 recommendation against screening for pancreatic cancer. And once again, the U.S. Preventive Services Task Force does recommend against screening for pancreatic cancer in asymptomatic adults who are at average risk. The reason for this, I think, is quite clear. Pancreatic cancer, while its incidence is increasing, is still relatively rare. And so even if we had a perfect test with 100% sensitivity and specificity, if we tested, did screening on all individuals, we would identify all of the pancreatic cancers, but we would also identify a lot of other abnormalities, which, we're doctors, so we're curious people. We would want to biopsy things that would cause bleeding, infection, so on and so forth. And so even apart from the costs, if we screen for pancreatic cancer in everybody, we would likely do more harm than good. We have recommendations from some of our large GI and other societies for screening. I'll show you the cover pages here and then summarize later. This is the CAPS Consortium guidelines for management of individuals at increased risk of pancreatic cancer. These were recommendations that were updated a couple of years ago. This is largely born out of the Hopkins group as well. And then we have our NCCN guidelines here. I realize this is a very busy table, but I'll summarize it for you essentially here on the left. So we look at the pathogenic gene variants for those with ATM, BRCA1, BRCA2, MLH1, MSH2, essentially the Lynch syndrome genes, and PALB2. And for this group of individuals, the NCCN, ACG, and CAPS recommend screening or surveillance essentially when there is a family history of pancreatic cancer that appears to segregate with the pathogenic germline variant, starting around the age of 50 or perhaps 5 to 10 years younger than the youngest affected individual. For those with P53, NCCN recommends screening when there's a family history. For Peutz-Jeghers syndrome, family history is really irrelevant, and we start screening at a younger age, somewhere between 30 to 40. For CDKN2A or FAM syndrome, we start screening also at a younger age. NCCN does not include a requirement for family history. CAPS recommends screening most certainly with the family history, and most of the members of CAPS recommend screening irrespective of a family history. For hereditary pancreatitis, we start around the age of 40 or about 20 years after the onset of pancreatitis. And then for familial pancreatic cancer patients, those with multiple first-degree relatives, we start somewhere around the age of 50 or 55 or 5 years younger than those that were affected. So to summarize the consensus statements for high-risk individuals and how to screen, it's either with endoscopic ultrasound or MRI. Once again, CT or ultrasound are not recommended, and follow-up imaging is essentially the same. In the absence of concerning findings, we do surveillance annually, and our targets of screening are resectable cancers that are confined to the pancreas with negative margins, high-grade PanIN, high-grade IPMN, and new to the updated CAPS guidelines were neuroendocrine tumors over 1 centimeter in size. So who to refer to our office? Really anybody who wants to have a discussion about their pancreatic cancer risk Those with the germline mutations that we've reviewed with the family history of pancreatic cancer starting at 50, multiple family members with pancreatic cancer, everybody with STK11, CDKN2A, or PRSS1. And I would also add those with a pathogenic germline variant with a pancreatic cyst on imaging should have surveillance, and then any at-risk individual with a change in their glycemic profile. So to summarize, there are several genetic syndromes that contribute to the risk of pancreatic cancer development. Smoking remains the largest identifiable and modifiable risk factor. There are precancerous lesions that we can identify, and I believe there is an adequate timeline for identification of precancerous lesions. Genetic counseling and testing are critical, but we have a lot more work to do to understand the long-term impact of surveillance. So I thank you for your time and happy to take any questions.
Hi, good morning, everyone. I'm sitting in for Dr. Thomas, who's away on a well-deserved vacation this week. I see 2 questions in the chat, Aimee. Do you want to review them yourself? Or you want me to read them to you?
I can review them. So I'll look from the bottom. The role of metformin in the management of pancreatic cancer. So we don't know about the role of metformin in the management of pancreatic cancer. We have actually performed a study in using the SEER database where we looked at people who were diabetic and with pancreatic cancer. And we looked at overall survival for those that used metformin compared to those who did not. We did find some improved survival with diabetics who were on metformin, but I think this needs to be better evaluated in a prospective fashion.
A question right above that from Dr. Greenberg.
From Dr. Greenberg. So since pancreatic cancer has significant fibrosis, and there has been speculation that fibrosis may limit the ability of drugs to get to the cancer. There was a study, perhaps in Science, where they were able to decrease the death rate in mice by decreasing the amount of fibrosis. Has anyone looked at the degree of fibrosis in familial cases? I am not aware of a study that looks at the amount of fibrosis in familial pancreatic cancers compared to sporadic pancreatic cancers. That's an interesting question. Ultimately, the number of cancers that we detect that are surgically resectable, fortunately, is low. And so this type of study would really require multi-institution collaboration. And we do have several of those studies ongoing, collaborative studies with a variety of different groups. And so I think this is certainly something we should look at in the future. And then Dr. Scigliano, I owe you an email about exactly this question. Does U.S. Preventive Services recommend screening for high-risk individuals? If you read the U.S. Preventive Services Task Force recommendation, they do very clearly state that the recommendation against screening is for individuals at average risk. They do comment on some of the data that I've showed you today. But the recommendation for people who have, let's say, 1 first-degree relative with pancreatic cancer who are considered still to be at average risk is for germline genetic testing for those individuals as per the NCCN recommendations.
Other questions? You can unmute yourself if you have other questions. I do have a question. At the beginning, I think you said something about some insurance companies will pay for some of this testing. Is there a significant disparity in which insurance companies will pay and which of our patients can have access to this testing?
Unfortunately, there is. By and large, Medicaid and Medicare will not pay for germline testing. I think there's 2 separate questions. There's germline risk assessment, and then there are paying for the imaging itself. So the Medicaid payers actually don't often pay for genetic testing unless there's a cancer diagnosis. Several of the genetic testing companies do have financial assistance programs. And so through our cancer genetic counselors, we are able to obtain genetic testing for many of those patients. But a lot of those patients don't. We have a lot of patients within Mount Sinai who have first-degree relatives with pancreatic cancer, and a lot of those individuals aren't coming to genetic counseling and genetic testing. The out-of-pocket expenses for germline testing nowadays, if it's not covered by an insurance payer, is around $200 to $250. So it's a big improvement, and that's for a panel test of 30, 60, up to 100 different genes. So it's a big improvement over the $3,000 expense for just BRCA1 and BRCA2 testing, but it's still a significant cost that can be a significant burden. In terms of the screening and surveillance, MRI and endoscopic ultrasound, I do find that more payers are paying for it, and I do fewer and fewer prior authorizations for those who clearly meet CAPS and NCCN criteria. It's a little bit more challenging when somebody, let's say, with a BRCA mutation without a family history would like to embark on a screening and surveillance protocol, because the payers do not always pay for it. And I'm not entirely certain that it's the right thing to do also for those individuals.
Okay, thank you. Well, it's 9:33, so we've covered the entire hour with this very interesting talk. I want to thank you very, very much on behalf of the Department of Medicine. And if anybody else has any questions, I'm sure you can direct them to Dr. Lucas directly. So thank you very much. It was a pleasure to have you today.
Thank you, everybody.